I think just 1 second. Do you see my screen, the big screen? Do you see that?
Yep.
Yes or no?
Yes.
Yes.
So you see the major screen, not the other one, right? You see the major, okay. So you see the full screen, not the, so I'm just gonna switch my lights off. I chose this seminar, this particular topic, implant restorative complications, predictable, unpredictable, because when you look at some of these cases, you think, oh, this is probably done somewhere overseas. I'm not gonna mention what country, but I'll tell you that this is a result of Sydney, eastern suburbs, done in 2009, and your problems. And you think that, well, and you know, when you look at the person's website, they're highly qualified, speaks very eloquently, but we'll talk about the work later on. My point is, we should be very careful when we get up on the stage and we talk about that, you know, we do implant dentistry, we do full arches, because it's complicated. So whenever I see patients, I like to think, what can I do to simplify the patient's life, improve the quality of their life, and what else can I do to simplify my life? And part of the contingency planning should things go wrong. That's a three things going in my mind all the time. And so we joined with Dr. Boyatzis today, and we talk about people presenting with more complex functional aesthetic concerns. And we tend to think that we're promising the world to the patients with good, you know, good aesthetics using implants. And some of these questions you already read them. What would you consider when telling the patient's request? What questions you ask the patient? The diagnosis, your treatment plan, and what do we do? And again, part of the reason, which I think, just trying to start the lecture up, is every time when I do a risk assessment, I'll talk about contingency and then risk assessment, because risk of implant failure, risk of restorative failure, risk of change of the patient risk status as the time goes on. And although age is not regarded as a contraindication implant placement, but age is per se as a risk factor because of people's health change. We don't see that. We are very mechanically minded, unfortunately, as part of the education. And it's because somehow it's easy to think that if I do A, B, C, it's going to happen. And I'm glad that Stan's here. I have Alex there, when we talk about Alex all the time. How do we plan this case before we place the implants? Because sometimes things are complicated. And I want to look at my technical expert to see how we're going to solve this problem before we start. So we have all the things in place. And, you know, for instance, when you look at this particular patient, and immediately comes in your mind is, to me, like, you know, you can see it's a bit of a tooth wear, failed restorations, chipping teeth, chipping restorations. I think patient's about 68, 70 years of age. And, you know, she just wants to improve the mastication, improve the look. And question that I would say is, no matter what you want to do, and we'll come to that, is, you know, what's the complications of the proposed treatment? What I'm really asking is, what is my contingency planning should things fail? How would I test the system? How do I do things? So, you know, immediately, I'm sure all of you will have some sort of an idea what you want to do in this particular case, and we'll talk about that. And the other thing I will talk about in my mind is, no matter what I want to do, does the patient understand all options of treatment? Because, doctor, you're the doctor, just do what you're going to do. Yeah, it's good enough for me, but I want you to understand what I'm going to do and how it affects you. So it's very important to have that in mind. And having said that, then we go to the next stage and we ask our patients, okay, how do you obtain consent from your patients? I mean, what, do you obtain consent from verbally, or do you give them something in writing? Versus, I find that when I see the patients, especially in areas of litigation, I look at a consent letter provided by a dentist. It's like a form. It's got all the complications just signed on the dotted line. And what I don't understand is, I explain this, did the patient understand? I'm trying to help everybody to get a resolution. Yep, he signed a consent form. And I said, where's your consent form? So a consent form is just one of those forms that ICOI provides, or other implant companies provide, put your name, sign on the line, you sign your life away. The answer is wrong. That doesn't work that way because that consent is not specific to that patient. It's a non-specific, stupid form. It's not worth the piece of paper it's written on. Would you agree with that, Stan?
Yes, correct.
Thank you. And so when I explained to the dentist that, okay, what's the next question that, we will look at this? And I said, well, why do things fail? Oh, it says patient didn't come back for treatment. That's interesting. Because when you think about losing risk assessment, not about just teeth. I mean, this is about teeth. You're probably waiting for me to put some titanium screw up on the screen so I can show you the titanium screw. That doesn't mean anything because people don't want implants. They want teeth. They want to function. They don't give a stuff about 1, 2, whatever it is. They want to have a tooth that is as close to their natural, and that's why they come to you. And they think that you're the implant guru who's advertised. When you get on their website, you see all this surgical team, and it's done so cleverly. I wish some people spend more time and expense on education rather than marketing. That would make it better for the patients. But nevertheless, we have a patient who's presents in your practice, and we're doing this assessment of consent and contingency planning. We need to think about patient level and tooth and implant level. So, and not only that, we want to look at the supporting structures, bone and soft tissue level, and then we got the technical area. So before we start, I will at this stage ask my colleague Alex, so look, Alex, we got this problem. I might be doing some, situation. How do you feel? What materials do you think we should do? This is what my suggestion is. And then based on we look at how much room we have, how much space we have, etc. Now you probably think that when I'm talking about Alex, I'm probably thinking about doing all on 4 or 5 or 6. Now, how many of you would consider doing all on 4 or 5 or 6 for this patient? Anyone would consider it? Anyone? I'd like a comment from my colleagues, please. Would anyone consider implant therapy for this patient? How many of you would think, this is too complex? You know what? You better get rid of all these teeth and just putting 4 implants on the bottom, because it happens all the time, because I get this patient afterwards, and put 4 implants on top and we'll fix you up. You have a beautiful smile, and it'll be perfect, etc. I mean, we're all humans, we all make. So, do anyone put their hand up? I'm just trying to think. How many would consider it? No chat room. Okay. Well, let me put it this way. This is the important part when we talk about in the college. We talk about how do we plan these cases. And the planning is the key. So when you have a case like you say, well, how do I do this case? How do I start this case? What important parameters would consider? And I know when Stan looks at this case and Stan, what would you do for this patient if the patient said to you, look, I'm considering having dental implants done. And what would your initial impression would be like? There's no mobility, the teeth are pretty intact.
Probing depth, what's the perio like? Probing depth, he's got a lot of precision. Pretty good. So you're looking at what, 2 and 3 millimeter probing depths?
That's right. She's in pretty good health. I mean, she came to me because then suggested that you need implants. And so is there another solution? I said, of course there's another solution. I mean, it's just simple. And, patient of age of, late 60s, early 70s, generally healthy would, I just couldn't see that implant would be the best option for this patient. I just couldn't see it. And I explained to the patient. But nevertheless, I'll come back to us in a minute because I want to get to the point. So when we talk about the college and what we do at the college is we try to make you think about the diagnosis and treatment planning. It's not about procedures as such. It's about trying to put things together in terms of understanding why, if we need to do these procedures, and how would it help the patient. It's not just about, I can do this procedure. Let me just cut this teeth. Let me take these implants out. his teeth out and put some implants, we got a whole prosthesis, and you don't have a problem. And that was promised to the patients in the initial images that I showed you. We'll come back to in a minute. But you see, my concern is always when you talk about specific risk factors for this patient. When we talk about, the medical history, we talk about their expectations. Is it, aesthetic expectations, a little bit of smile line, somebody with a very high smile line. That makes implant dentistry very complicated. And those of you who can answer, I'll be happy to listen to your answer. And also the type of gingival biotype, how much bone resorption we have, and naturally the amount of volume of bone that's present, and look at the occlusion. There's all the other factors. I put some few of them just to make it easy. So the problem is that whenever we talk about dental implants, for some reason, what comes in the question is aesthetics. Okay, because talk about aesthetics, and and everybody wants to look good. Doesn't matter what age you are, you want to look good, because when you look good, you feel good, and that's quite common. I mean, the idea is to imitate nature, and if you have a really good technician and provided you've done everything right from the implant point of view, and he will make beautiful prosthesis and provides hygienic, provide pain doesn't deteriorate. Maybe the first few years will be fine, but after 5 years, what happens? We like to think about that. So without much problem, the patient comes in your practice and he says, look, I've got a fractured tooth. And you look at this tooth, you can see there's a mesial-distal fracture here. And you can test the fracture. You don't necessarily have to have a curved CT, but it's quite obvious that in this particular instance, we have, you can see there's a vertical line, there's periapical area associated, and this tooth is unrestored. It's unrestored, okay? So I tend to think about, why would this happen in the first place? And the patient's been regularly going to the dentist. See, one of the things we filed in our diagnosis is that when patients come regularly, we don't test their occlusion to see if there's prematures. Now, Stan, would you make a few comments on prematures? How important it is from periodontal's point of view, please?
With tooth mobility, right, it's increasing mobility over a period of time. If you can stabilize that, yes, because if you've got inflammation plus mobility, you'll get further breakdown. It's not just the mobility by itself, it's the combination of factors.
And that's how you get infrabony bone loss as well.
See, in this particular case, it's an isolated tooth. Obviously, what was the occlusion on that? Had it been changed? Because if you've got a large restoration on the 6.
Yeah, that's right. So it's changing loading, it's altered loading pattern. Okay, they were changing loading. They placed the restoration on the 6, and suddenly patients started loading on the 5. Issues a clencher, and they're notorious. And rather than, the transfer the load to the 5, and 5 is just vertical split. I mean, it's quite obvious where the problem is. And we so look at CT view. You can just see it's quite obvious. We remove this tooth just to show what I'm talking about. Vertical, fracture, and naturally you can just see how. So the issue was when patient was promised, look, go to Dr. Narbani and he will place an implant for you. And which I'm happily doing. I'm always grateful for the fact that we get referrals coming through the door and happy to look after our patient. But my answer is that, could this have been prevented? Okay, and could we have prevented this from happening? You see, this is the way diagnosis and treatment planning is so important. Everything starts from small area. Everything starts small and gets bigger. So, when Stan, one of the problems we have with a lot of the college students, they're saying, do we really have to do diagnosis and treatment planning? Can't we just go on to the module of occlusion, on veneers, on crown preps, on this? And I kept on telling them, this is a procedure based, because it's a procedure, but if you do the procedure without understanding where you're going, where's your end point, then it will fail, because procedure doesn't guarantee you success. It's a diagnosis contingency planning based on your clinical findings that gives you feasibility which way would you go? Would you agree on that, Steph?
You treat a patient as a whole, not individual. Like this patient came in with a fractured tooth. At present, that's the only isolated problem. But if you look at it overall, is that going to happen tomorrow on the other side?
That's right. That's right. That's exactly what we did. We went round and we improved the occlusal loading on and redistributed loading the rest of the teeth. And then we allowed things to heal and proceed with an implant placement for this particular patient. And the patient completely understood. The trouble is that we don't see this patient sometimes after a long time, and we don't know what happens to the work we do. So I'm making a point of recalling all these patients after 10 years and see what happens when they turn up. Now, coming back, you can see that, in many ways, there's a root fracture goes straight up, even a simple crown or the patient. And what about the anterior root fracture? Okay, again, I see on the, standards of Facebook called DPR, where everybody puts their great work and it's fabulous, but nobody talks about why things happen. It's rarely people discuss the reason for failure. And the root fracture is quite obvious here. And in this particular patient, we do understand the trauma, the parafunction, the design, the post design, the core design, all the important factors, how much loading was placed. When I look back on this, you can just see the amount of loading on the palatal that was kept on adjusting. Eventually the whole root just tore apart. Okay, it's a complex root fracture. And it allows me to think sometimes where, the critical question asked is, why did this tooth fracture? So because the same forces that created a fracture on this tooth would be acting on the implant. Would you agree on that, Sam?
Yes.
Okay. So we have a problem where the loss of this tooth was occlusally related because patient was bruxing on this tooth. Somehow it just somehow could have been prevented. So when we place the implant, how do we manage the occlusion to prevent such a catastrophic failure? Maybe implant won't fail, but with a constant fracture of a prosthetic screw or loosening of the screw, and sometimes you get implant fracture if it's very strongly cold welded in place. So, or you get opposing to a fracture or opposing to a wear. So those little things we need to understand that root therapeutic teeth generally have higher fatigue, they have a low water content, so they're more brittle. And the parafunction. So all the things that are comfortable with this concept, we need to understand that teeth are different to implants. The fact that teeth have periodontal membrane then move to dissipate the forces, and when you put an implant there, it's going to need 10 micro movement, which is the same movement as a bone. Whereas the periodontal membrane has got between 30 to 75 or 90 millimeter of a 90 micron of tooth movement. So a lot of the things that we do is, and the things that fail is multifactorial. So when we have a heavily restored dentition, and I see people proudly show that the cases are heavily restored, is what happens after. Not what happens when you put it in, but what happens after. Most of these cases, 5 years and hopefully 10 years. What do you think of this statement so far?
It does happen, and that's basically how do you prevent it? That's the main thing, right? And that's obviously right. Your treatment planning initially.
That's right. I agree. And this is a problem that patients somehow don't buy into the treatment to say that there's a maintenance protocol starts from your initial assessment and diagnosis. That this is part of treatment. People take their car to a service, but they never take their teeth to a service. That's another problem. So, reason for tooth loss. When I look sort of back in terms of understanding why, we look at the biomechanical factors. I mean, what am I talking about? So I'm talking about geometric risk factors. And now what's a geometric risk factor? Well, that's interesting. Occlusion risk factors, bone and implant risk factors. So all these technological risk factors, okay? That's where I talk to my good colleague Alex about, Alex, we're going to design this. How do we go about designing it? Sometimes I talk about, I think I should put the implants here to get better forces here, better this, we can design this way. So we get opinions. It'd be surprising how having few people that you mentor around about how much you can do the cases. I'll tell you what, when you're treating patients, it's not about your ego. It's about learning what is the best for the patients. And the patient is a very important decision maker here, because they look at the situation and say, right, this guy's really telling me all the important things I need to know. So, and we apply this to every tooth with implant support prosthetics here, because it's designing implant or tooth support prosthesis that gives you the most predictable outcome. And the patient is an important decision maker here, because they are, after it's their health, it's their body, and we are in a privileged position to make the right, decision for them and help them to make the right decision and treat them in the best and simplest possible way. So the problem is that why we have to apply this, in every case. Every case that I do, I would look at all these 4 important factors plus the other ones we discussed, because when implants or teeth prosthesis fails, after loading, if you have an implant prosthesis or you've lost of implants, the cost of replacing is about threefold. So, and it's never the same. You lose bone, and you might require more grafting. Placing implant in the grafted bone may not have the same success rate, so it's complicated. And the real cost is really biologic cost, because you lose a bone. You lose a lot of bone with implant fails. So it seems to be that many times the implant companies keep pushing the product to those who really hasn't got a lot of experience in implant dentistry. And someone needs to say, okay, well, you're doing all this to the dentist. What about if implant fails? Who's really responsible? Is it the dentist, the company who sold the product, or the patient? Where do you go from here? Stan, I'm sure you get this problem happening all the time. Patients come to you, they say, took the good tooth out, a good tooth was saved, the implants are better now, I've lost their tooth, I've lost the implants, I've lost all this bone, we're going to graft. How do you deal with this situation in your practice then?
Once you accept the patient that you will be treating him, the responsibility falls back on you, right?
Right.
So once you accept that, you can say, no, I'm not going to treat you. That is acceptable. But once you say, I'm going to treat you, you then are responsible for the best treatment for that particular patient. It may be a referral elsewhere, fine. But then what you decide with the patient, and you sit down and you go through each of these factors, right? What it's going to cost, what are the complications, what can be achieved.
That's right.
And all this has to be explained to the patient before you do anything, before you start treatment.
Absolutely. And when we get this complication, which I'll discuss soon coming up in the next few slides, you realize that something hasn't been explained to the patient, and let's go through that. We look at this case, for instance. This lower slide is the patient that we showed earlier with the tooth wear, and we have another patient here that's got missing teeth in periodontal situation, and it's unfavorable occlusal context, wherever it is, doesn't matter, and they have minimal space to restore the arch. In all of them, this is teeth, and this is we need to restore the arch. There's not enough room to build. You have to open and bite, etc. And and the presence of wear is not normal, or presence of wear is not conducive to restorative treatment for the patient. And naturally, patient will be a severe bruxer or a clencher, and there's a parafunction. And also, when you think about it, you've got bruxer periodontalis is absolutely lethal, like Dr. Boyards has explained earlier. See, the problem I have is that these two patients are totally different things. This is a patient with periodontal problem, with collapsed arch. It's in the short dental arch, and you can see there's a mobility of tooth number 2-1. While this patient's got a very good bone support, minimal probing debts, severe bruxes, a teeth wear, but things have stayed pretty normal as 1 or 2 caries that needs to be resolved, but patient's functioning pretty well. Got good periodontal support. So we have 2 different patients here. And in many ways, when you think about those patients, is that, you find there's a history of repeated fractured teeth, history of repeated, crowns, finding that this crown still survive in a high occlusion. It's interesting because normally this tooth would have fractured, but some of there's been compensatory movement around the arch, and this has stayed intact. But that's interesting to me because that you better smile used to be for this particular patient. That's like a reference point I can build a smile for the patient. But that's not the issue here in this question. Now, what about this patient, Stan, where you can see the implants are placed to restore. We have 4 implants on the right. And if you look very carefully, the whole mouth reconstructed. And when the patient presented to me, she had a temporary bridge work that she couldn't accustom to. So she'd been like this walking around for almost 6 months and can't get used to the bridge, the permanent bridge, sorry, the permanent bridge. Where do we go from here? I mean, this is a complex problem that I have to face. And the implants are placed and was sent to me, look, you know, I don't know what to do with this patient. Can you please sort this out? Now, Alex, is a question for you. Okay, what do we do in this case?
Well, I mean, if you're not sure with what you're going to be doing, you definitely have to go to some sort of a provisional.
Mm-hmm. And how do you feel?
I mean, I'm looking at this now and I'm seeing crossbite situation here in quadrant 1 and 2. Sorry, quadrant 1 and 4. I'm looking at possible screw chamber access from the labial in quadrant 2 on that 2-4 region. You got implant versus implant. You got
this is implants here. This is implants. There's a direct this implants here.
Yeah. It's tricky because you got no give.
Yeah, give. I'll tell you when I look at this. I know what Stan's looking at, but I'm going to answer for Stan, but he can come in a minute. From my point of view, this is a real concern, that last tooth here.
Yeah.
Okay. And you know what's going to happen here, right? When you build this teeth down, that's going to be banging on those, right? Okay. That's going to be really interesting. And other concern that I have is that these are really heavily zirconia type of restorations. I mean, I probe these margins, and I'm sure Stan's looking at those things. There's just pockets everywhere here, Stan.
Yeah.
There's pockets everywhere here. There's a millimeter ledges all around here. You can put your perio probes. There's a millimeter ledges. Patients got a thicker biotype, which compensates at the moment, but you can see all the marginal erythema, can't you, here, Stan? Can you see that?
Do you have any radiographs of this particular patient?
I didn't want to show the radiographs because you wouldn't like what you see.
We've got to see it.
I agree. I've got a CT scan, but I didn't want to show it. There's all bone loss here, Stan. There's a bone loss here. Okay. And I'm just looking at the occlusion here. I don't know what there's a dip here. I mean, you have a yes question? Also, there was someone. So, I mean, when you think about this, I want to talk about the patient's concern. I'm going to bring the patients now in a minute. Now, let's talk about this patient here. I'll come back to this picture in a minute. This is a very common occurrence in my practice. I have to tell you, this is not first time. This is all the time. We have different types. So we have this case, okay, when the patient is smiling. How would you like to restore this? Alex, how can we restore these and restore it to good aesthetics? How can we do it?
Oh, you would definitely have to go with, I mean, the first step would be with a provisional for sure. PMMA.
But even with provision, you think you'll be able to restore aesthetics here?
Well, you have to start with something.
I agree.
And you got what? You got 4 natural tooth-borne crowns there, right? They're
right.
tooth supported, and then you've got. So, is your plan to retain those front 4 teeth?
Well, it's been crowned. It's not my plan. It's not my plan. It's been given to me. So,
okay. So what's the question you're asking me?
The question I'm asking, okay, the question I'd like you to answer is different. I'll say, you're saying going with a provisional, but how would you do the provisional here?
In what do you mean, how would I do it? You would take a fixture level. Are you going to do this at a fixture level or a abutment level?
I don't know. How would you make this patient happy? Because she's not happy with the whole thing. She likes the whole natural smile. That's what she wanted in the first place.
Okay, well, if that's the case, I would restore this. We would need to see how deep the implants are, preferably an abutment level impression, and we would go to a provisional.
I know, but you're talking about procedure here. The problem here is aesthetic risk factors. You understand? The problem is the aesthetic risk factors. Okay, this is an issue. You have a high smile line. That's not high enough here. You have a high smile line. How are you going to get the level of aesthetics in this particular patient? Not the right side or left side. How are you going to get this? How are you going to get that right?
Well, you've got those 4 front teeth that you're dealing with as well. So what are you going to do with them? If that's your benchmark.
Patient's main concern is when the dentist placed the implant crowns of the bridge work, it was not what I expected.
Okay, is that what the patient said?
Mm.
What did she expect?
Well, that's a problem. It was not addressed. You see, the aesthetic expectations was not addressed at any point before the treatment started.
Right.
Okay, was not addressed. Now we can talk about treatment for this patient, but let me assure you, this is not going to be a simple case, because what's really a problem here, in your opinion, Alex? What would be the biggest problem here we have?
I mean, there's multiple factors here. You know, I mean, there's clinical issues there, obviously, that are underlying that we're unaware with, but it depends what, I mean, is there an option of extracting the 4 teeth and going to an all-on-4 with acrylic titanium style frame? So that, I guess, that makes a buffer against the lower dentition. Or either that, or if you decide to choose to retain the front 4 crowns, then you have to work around it, and you at a compromise.
Well, let me ask you, would somebody else in the audience?
Dr. Sarkis, Jesse says symmetry, and Dr. Christina Howard says provisionals. Chanel says we need to treat the face.
Mm-hmm. Treat the face. See, let me explain to you. One thing that the patient clearly is very upset, extremely upset, is the fact that why do you think this patient presented practice for have fixed restorations? What do you think is the reason? She's a very lovely person. What do you think people will come in and want fixed replacement of their teeth? What's the main reason? Especially for women in the late 40s.
They don't want to wear dentures.
That's right. And it's something that about their life, about their being, right? About their personal intimacy, about their status of their homeostasis, of their biopsychosocial well-being. And so the problem is that patients presenting in the practice, where dentist promises that they're the guru in implants, is like the old saying, I can teach a monkey how to cut a bone and place an implant. Is that clear? But I can't teach a monkey how to be able to finish the case. So this case is an aesthetic failure, okay? This patient is never going to be happy. It's never going to be happy. Because there's no way, Alice, you can create a transition from this area, okay, to create a nice smile, or from here to create a nice smile, because this patient's completely, okay, he wants to know why is this implant so high up there? Why there's a big vertical defect? Because he took this teeth out, he says, I'll put 3 implants to be better. Now, before this tooth was taken out, that line of bone was about here, and it should be comfortable. So premolar was removed because it was a better outcome. That's not the issue. What it was failed by the dentist, treating dentist, to explain, we expect a vertical defect. We expect prosthetic gum replacement, because vertical bone augmentation is very unpredictable. Stan, please comment.
This one worries me a lot. There's still active periodontal disease, right? There's implants there, and we know that with periodontal disease, if it's still active, you're still going to have problems, or you are going to have problems around those implants. So my first thing is to stabilize what teeth you're going to hang on to. If you decide to take those front 4 teeth out as part of your treatment plan, fine. But if you're holding them, that's why I wanted to have a look at the x-rays. What are the probing depths, and especially the low anteriors? because until you can stabilize the gum infection, the gum inflammation there, you're asking for problems around those implants.
Stan, I asked the dentist for a period chart. He didn't do a charting. He's restored all his bottom teeth everywhere.
Why were those back teeth taken out? Was that because of periodontal treatment or periodontal problems that he had there? Why did they take
That's
them
right.
out?
That's a good question. Well, this work was, they were treated in the Soviet country, and basically had infections and had therapies that were removed. But the problem is here that no attention was paid to periodontal tissues. And these crowns, these zirconia crowns, are extremely poor fitting. And you know, Stan, that there's too much emphasis on people placing zirconia crowns when the actual fit of the zirconia crown, subdigital margin, and the cement retention is just notorious for periodontal health. We all know that.
So you're looking at a patient who's in her 40s. What is she going to be like in her 60s,
right,
in her 80s?
That's right. So that's never been taken care of. So I'm expecting, Stan, avalanche of these cases coming into the surgery where people require treatment and retreatment. So I don't know how I'm going to do this, but and I'd like any answer from the audience that could help me in managing these cases. That's going to be more and more common in the practice. And you can see when I rang, I said, look, would you mind? I mean, to me, I find this very difficult to treat. And it was never addressed to the patient. So I couldn't treat this patient, Stan, because she didn't want to accept what I suggested. And so she's gone back to the treating dentist, and here I have no idea how far I have progressed. But nevertheless, I will be temporizing initially upper and lower arches completely, and doing a lot of other treatment before I go ahead and do any definitive crowns for this patient. If I was given a chance, I had to explain to the patient, from my point of view, I have to replace the full mouth before I go ahead and make a full temporary, change the occlusal prescription, and do a lot of other things, and then make temporaries, and then reassess for about 3 to 6 months, and then we go back and restore it. And I think she paid a lot of money to have up to the stage, and naturally the cost of replacing this would be very, very expensive. But this is the problem of unplanned dentistry, okay? Unplanned dentistry. It may look good because I've done a big case, I'm the king of the town, because I was major reconstructive case, but the consequences is devastating to the patient. When things go wrong, the contingency planning was explained to the patient. So my concern is that where do we think, how do we plan? How do we have a treatment sequence? Where do we manage the case? There's a common slide. We stabilize control, okay? Periodontal tissues, the supporting mechanism, okay? Occlusal prescription, okay? Recess, see how well is the patient responding. That's your diagnostic phase, okay? If you do temporaries after your perio, you can do temporaries. If you recess, now definite treatment, fine, but you know what? There may be a lot of stages between here and definite treatment. Maintenance, but this maintenance starts from stabilized control. Patient's not going to be able to come to your maintenance program. You're not going to be able to treat this patient. You see? I mean, the problem is, I explained to the patient that when you start the treatment with us, you have to be part of the family. If a periodontist colleague of mine treating you, I'm treating you, you're going to be with us all the time. That's how we manage and look after you. If you can't do this, I can't look after you. You have to learn to say this to your patients. When you're treating your patients, it's imperative that you do this every day in your practice. This will give you a better outcome, treatment outcome, and you feel more confident treating the patient because you've done the right thing. We specialists are always here to help you in your treatment outcome, in helping you planning the case. So planning is very important. So having said that, when I come back to this particular patient, who presented, at the age 65, and you've probably seen the slides before, and when she was suggested that we can take your teeth out, put some implants everywhere, And given the cost of, I think, one guy gave a 40 grand, another guy gave 65, another one gave 80, irrespective. I said, look, I really don't understand, because, I mean, really, we can really change. This is one visit using a simple composite technology. This is only one visit, you know, with no injections, with hardly any, you know, we doing all the normal dentistry that we used to provide to our patients. And you can see that most of the patients are happy with a single shade. It looks like there's multiple shades here. I love when people roll this VPR or the little composite build-ups, a little shading, when it doesn't really mean much. Most people are happy with single shades. And then Tifrolex for these composites, they look pretty good. I mean, people are happy. You see, what I'm trying to explain is that when dental colleagues try to do this complex treatment because it somehow fits their ego, or somehow they want to make more money out of this case, just remember that when things go into complicated mode, there'll be consequences. And this is what happens. Now, I know there's no composite reconstructions. If my composites wear out, that's okay. I'll just go and add some more. I will sandblast, put some bonding, and keep going. I mean, Stan, you've seen these patients come in your practice years after years. And we maintain these patients with a minimal outlay of income, with minimal biological intervention, okay? You know, we have to understand that most patients need simple and effective treatment. And then bless you for that, because you change your life with simple treatment plans. Yes? Now, when we look at this particular patient, okay, you can see how with simple composite additions, okay, we were able to go from there to here, and you change this patient's life. I spoke to her recently. This is in the mouth for about now 4 years, okay? She said there's some little chipping. That's fine. I said, if you come here 6 months, we'll be able to restore you. So the point I'm trying to make is that, did this patient require dental implants and require removal of all the teeth, okay, and implants? I mean, why would you treat this patient with dental implants where simple treatment modalities that's been with us last 60 years will do the job better and non-invasively? It just disturbs me, Stan, when I see these patients and look at the previous dental records. I knew for a fact that I could save those teeth. Would you please comment on that, Stan?
No, I agree with. Can we, probing depths, what are these? We're missing out. Sorry, as a periodontist, I need to go back to some.
I'm happy. You know, you came in the last minute. I'm sorry, Stan. Had I known you coming in, I would have brought you all the charts, okay?
That's okay. So she was fairly stable from a periodontal point of view.
We have a few hygienists listening to this conversation too, so obviously they like to think the same. Is that right, Chanel?
Dr. Sarkis, Khan Ravi asks, how did you manage the deep bite in here?
The deep bite, very simple. If you open the bite, it's very simple. We didn't just do the deep bite. We actually improved this patient's lower facial volume. This is aesthetics and function. They go together. We restore what's missing, okay? And then there's many ways of doing it. We did this in a two-way. Whoever can attend my two-way lecture, they would have seen this case. And this is a full day lecture on this. We can teach you that. I mean, I'll put those lectures. I will run some programs soon on short courses before the main course starts in January. But you will see all these patients come in the clinic. They'll be happy to show their teeth, and you can examine those patients. I mean, this is every day. You can actually walk inside the main street and drag these type of patients in your practice who really need dental care, and they've been told you need 50 grand or 60 grand to fix your teeth. But they'll fix the teeth for this patient, cost a fraction of it. It was only one visit. Okay, I'm just trying to make my dental colleagues understand that this is what we teach you in the college. We teach you how to think, how to diagnose, and how to do the procedures based on a good diagnosis and treatment planning. How do you talk to your patients? How do you get a consent from them? Okay, you know, give them the right information And when people say, I want to have this work done, what is it that they want? Understand why they want to work done. Don't try to sell dentistry. You got all these gurus now who advertise how to make $15,000 a day by really selling your point. And they're really gurus. And I've seen those gurus. They're great guys. I've seen their work too. The thing is, do the best dentistry, the simplest dentistry, and you help your patients. Because if you don't help your patients, if they can't afford the dentistry you provide, then what's the use of treating patients? Because this look can eventually lose their teeth. Okay, they can't afford implants. And this is a stage in their life of, I don't fix teeth, she's going to start destroying those teeth what's left. Then she'll end up having more complex work to be done. We got there just at the right time to reverse and improve this patient's biopsychosocial well-being by improving the lower facial height, improving the overall well-being. And she's a totally different female. Look at the whole change you made this woman, okay? By a simple treatment, okay? It probably cost her a good holiday, to go to, White Sunday Islands, but this is better than a holiday, okay? This is how they are. They will bless you because you really care for those patients. And we can show you lots of, we have terabytes of cases of these patients. Coming back, patient presents in your practice, failed toothbridge, been there for 15 years, okay? I mean, if you think about it, take an x-ray, there's a fractured root, okay? There's a problem here, there's angled, and you think, well, we're going to lose this teeth. You find there's another problem here. There's perio problem here. I don't know why this crown, this is red here. It's not the invasion of biologic width. I don't believe in that. There's a problem here that's brewing. So all these patients, gum recessions, okay, look, probably that, I'm sure there's an issue there as well, Stan. But looking further, there's another infection here. Okay, and what am I thinking? Look at dynamic occlusion. This bridge is loading. Something happened period of time. Patient has got hardly any anterior guidance. It's loading on the left side. Patient rocking left, right, left, left. Of course, with the crown, that's not going to wear. There's no wear of natural teeth structure. Things will have a give, especially if you have a tooth that's root therapy abutment teeth. Okay, it's been 15 years. Fair enough. It's lasted well for the patient, but the problem is when people say it lasts longer than this and longer than that, but you know what? At the end of the day, when things fail, it's dismal. We do lose lower tooth structure. This is the problem that I face sometimes. And look over here. Okay, that's also loading. There. Okay, there's no guidance. That's why we look at occlusion. So before we treat this patient, we need to manage the forces. Occlusion is forces. How do we improve, our future restorative outcome? Okay, and in many ways, you can see on the left side we have the same problem. So if a patient's going to have an implant, well, I'm not going to do implant yet, but I'm going to have to fix up a lot of things here. We're going to put some implants here, but we have to fix a lot of things to create a favorable loading pattern. Meantime, parent is looked at. Patient will end up seeing my therapist or Dr. Stamboiatis to get this sorted out. Okay, learn to share the risks with the patients and take them on. You see, biomechanical risk factors. Okay, occlusional risk factors. How do we plan out? Yes? Is there a question, Shraddha?
Because there was just somebody in the background.
Okay.
Sorry.
Okay, that's fine. But my issue is when we look very carefully, okay, what really has failed? The bridge or the supporting teeth, okay? Is it a technical or biologic failure? We can answer those questions. Is it a technical or biologic failure? Okay. All right, and this biologic failure could have been prevented by correct design, by correct diagnosis. Okay, don't bring the patient in your surgery. So open your mouth, let me have a look. Oh yeah, we need this. We need a crown here. I need a bridge here. You need an implant here. That doesn't work that way. Give them a good rationale why. Look, I like to know, for instance, doctor, what is your rationale for doing this in a particular way? That's a simple question. What's the science behind your reasoning? We need to ask these questions, be able to treat our patients. Not because say, I've seen one, I've done one, and I'm on a lecture circuit. See, this takes time to diagnose. Okay? This could have been prevented, this catastrophe. I can assure it could have been prevented. And then someone orthodontic treatment, move this tooth in a better position, or even remove this tooth and place 2 implants. reduce the loading in that one, that'd be fine. Okay, that's the case, that's a better long-term stability. See, when you think about data that's present, okay, and they looked at, the literature looked at over, 2,000 publications, 15 studies, only fulfilled criteria. Inclusion overloading is a primary ethologic factor, it's American, that's why it's not A here. Okay, and treatment complications. Okay, it could be margin bone loss fracture, stomach veneers, porcelain rotation device, denture-based fracture, implant fracture, the whole thing. So, occlusion overloading was possibly associated with parafunctional habitus of bruxism. So you got patients with bruxism. How do you create, what is your occlusional prescription for the bruxing patients? That's what we teach at the college. You start suddenly, once you learn teaching at the college and the philosophy, you start asking your question before you start doing the case. Then you start becoming a really good doctor. You say, how do I do this? If I do this, that's what's going to happen. No, I better do it this way. And at college, we got a whole great team who's happy to help you in planning your cases. Become part of a greater team, greater support system that will help you improve your practices. That's what it's all about. Well, coming back to our patient origin I mentioned initially. Okay, here's our beautiful, I spoke to Maria today. She was actually going to join in the webinar to talk about a case, because you need to understand how people feel when the damage to the patient's iatrogenic. That means a dentist-related damage. Not a patient-related damage, but a dentist-related damage, okay? It's frustrating sometimes, but we have to face the consequences. We all done so. I've done my failures, but I've learned pretty fast as well. But the thing is, the ultimate failure is for the patient, okay? People say we have 98% success rate. Yeah, I want to know the other 2%. Was that the 100% success or failure rate for those two patients? Whatever. The issue is, when you're quoting research data, remember, it is not your data, it's the paper data. It's how was the research done? You need to learn how to evaluate the literature to be able to think, okay, can I use these values? How can I improve my, procedure skills, whether it's a prosthodontic skills, whether it's a surgical skills. It's not like becoming like a tradesman, Brennemark had a great quote. It says, implant dentistry is not carpentry. Implant dentistry is biology. He knew how to respect the bone. He knew how to respect the physiology of bone, maintain vitality of the bone. There's so many factors involved in understanding. This is why I want you to think before you drill. Think before you cut. Think of the consequences and the final clinical outcome that you're going to achieve. When you look at this, the denture business is going to growing area. There's a longer living population. We have a longer living population. Australia is very, very similar to the I think very similar to Germany, Sweden, UK, similar, or probably halfway up here. Because many times, above 65, you have about 3,000 to 4,000 per million, 3 per 100 for 1,000 in terms of being a dentulous. And when you think about this, the dentulous is increasing, and all these people are going to want to have dental implants. And that's exactly what this beautiful lady did. When we think about this patient, okay, all she wanted to have a fixed dental implants. That's the dentist every time.
I couldn't say it.
Okay, and she got something like this.
I remember that.
Okay, all right. So when you're thinking about this, I mean, Stan, how do you feel about this case?
When you say treatment-wise, or what did she want initially?
She wanted a fixed bridge work. She ended up having a few implants between canines and between the lower canines. And I'll show you some X-rays. I'll be showing an X-ray here. And she got 6 unit bridge work on 4 implants. There were 5 placed between the teeth. This is recent. This is done in dentists in Eastern Suburbs. And this was placed, and
holy shit.
okay, when you think about it, Alex, I can hear some comments from that end, and it disturbs me, because how do you fix this problem? And the last patient you saw, the problem was on the posterior segment. This problem is in the anterior segment. So how do we fix this problem? I mean, is there a problem? Yes, there's a problem. Okay, and what's the present solution? How do you fix this problem? You can see labial sinus draining. There's some infection here. Fractured teeth. I mean, there's an ill-fitting prosthesis. There's more there. I'll show you a bit more. And, you know, there's a smile line. I mean, how do you fix this problem? You know, when I spoke with the dentist, he said, my implants are integrated. What's your problem? So it's a problem because on a website, when you look at their website, everyone's smiling with dental implants, not this patient. So it tells us a serious concern about how the treatment was planned and how the implant was placed and how the patient was consented, because this patient was just want to have fixed teeth. You know, when we talk about risk assessment, information is information, it's not knowledge. It could be fake news, but this is real. This complication is real for this patient. It's very disturbing, okay? Because I don't have a solution. I have a solution, but it may not be the best solution for the patient, but there's only one solution for this patient. So the trouble is that, you know, whatever we do, there's an infection here, there's a sinus, must be something happening there. The patient can't clean their teeth. So normally implants are placed incorrectly. Prosthetic design is incorrectly based on the implants. And the patient just can't clean teeth. All she wanted to fix bridgework. And I can assure you there's bone posteriorly. For some reason, that is placed between the canines. We got anterior 6-unit bridgework on 4 implants, but there's 5 implants between 1, 3, and 2, 3. The more the merrier. See, think about what's a complication, okay, and what is a failure. It astounds me. See, in a patient presentation, in the clinical findings, the expectations. So when a patient comes to us in my practice, how do I feel about treating this patient? I mean, wouldn't you get angry? Would someone get angry? I mean, I don't know, if this was your sister, your brother, or your mother, wouldn't you get angry? Anybody? Okay. Dr. Howard says lack of planning and stage design. I would say, Dr. Howard, there's also lack of empathy. Okay, lack of empathy. Lack of empathy. Okay, let's show some x-rays. Stan, I hope you won't be concerned. I'm going to show you this. That's the x-ray. We got periodontal problems, obviously. He got 5 incisors. Human species doesn't have 5 incisors a day on lower arch. And when I rang the dentist, just didn't think it was an issue. They didn't think it was an issue. It was more of a concern to me. That was concern to me. Okay. You know, Peter, look at this. I mean, we have major issue here. Okay. That's a slipping implant. There's no planning. There's no planning. I can assure you if I did this, I wouldn't practice as a specialist. I'd be gone. I'd be finished as a dentist. Okay. This is the problems you have to deal with now. Remember one thing, when you do implant dentistry, you're either 100% right or you're 100% wrong. There's no halfway through. There's no halfway through. Would you agree with that, Stan? You can't say, oh, I have 50% right. That doesn't work in implants.
So what would you have done with the implants?
Yeah, I want you to comment. I want you to comment on my statement. Implants are 100% right or 100% wrong. Would you agree?
When you say 100% right, what do you mean by 100% right?
Well, they're either 100% right or they're 100% wrong. There's no halfway. You know, you have to put them in the right place to fix them correctly.
Oh no, if that's what you're saying is right or wrong, I agree with you. But there is you can use implants and natural teeth. You don't have to go one or the other way.
Of course, of course, of course. Well, when the patient initially presented in my practice, you can see, I'm talking about the face end now, where this is the whole planning process that's so wrong. Because even when you do a dental treatment or related to tooth support restorations or implant support restorations, you look at the face. And it's a smile. How would you feel this lovely patient? I mean, what do you think, Stan? Do you think this patient's life had been destroyed?
Definitely. When you say she wouldn't be happy with that, that's a...
No. So not only have you done it wrong, but looking at the other side, this patient's life has been put on hold, destroyed, okay? I mean, being in coma for 1.5 years, they're dying. This patient has got a life sentence by a dentist. I was hoping she could come on a webinar, but she said she couldn't make it. Oh, I have to talk about it stuff. I mean, you should hear what people say. Because when you talk about dental implants, Stan, everyone shows me the beautiful pictures on the website, but I want to see, because I see those cases here. Now check out this dentist site. Wow, great website, but I want to see the work. This is the work I get. So something out there that either we are not telling the public the truth, okay, and trying to get more business out of dentistry, which is very sad. So if you did the college, there's no way you would do work like this. You would think ahead, you know the consequences. It's a life sentence for you. It's lovely. She's the most delightful patient, but she's the most delightful human being. Okay? All right? Looking after her husband who just had a recent kidney transplant for the last 10 years. And they said, well, you haven't complained. Your complaint was too long. She's looking after a sick husband. It could have been, you know, couldn't pursue with the complaint. But we can actually pursue this. I'm definitely on this. So everything's wrong. The implant's placed right in the middle. I mean, don't talk about it, just to discuss. But, you know, upper bridge work. They place more palatable because her teeth are actually more forward. So patients, the third sound, the labial, the lingual dental sounds, she cannot pronounce. And being a Spanish background, the third, she can't speak the language because they use a lot of those phonetics quite often. And so tongues are restricted, can't speak fluently. Upper lip support is completely gone. You can see on the left side, okay? And again, the reduction of the lower facial height and increased folds, which is accelerated aging for a female. And she was offered to some both filler. I said, you're gonna be kidding me. Okay, there's a lot of issues here, okay? I mean, you can see the transition line. So Alex, I was telling you about the problem I want you to talk was a transition line. So that transition line for that previous patient is a problem that should be addressed before you do the dentistry, okay? Yes. Static zone. You understand what I'm saying now? Transition line, okay? That you cannot copy it. Patient has to understand the limitations. In that case, you may have to do other measures to be able to prevent that from happening. And I'll discuss that probably in part 2 of this lecture during the next webinar. So what I'm trying to say is that implant planning, same patient. Look at the position of the sleeping implant. There's a preimplantaris draining. I mean, that's not even loaded. You couldn't put that in the arch. So they would have tried, but it didn't work out. So look at the position of the implant placed. I mean, I don't understand. I don't understand how these things work. It just makes me you know, very, very irate in watching this case, and I have to remove this. You go to the angulation of the implant. Was there planning? Not really. So I'm trying to answer your questions then, where I end up basically removing the bridge work. I mean, everything that has to be, you know, all the scenes of implant therapy has been integrated in this treatment, okay? And I just don't understand why would a dentist sleep well at night sometimes. I just don't understand it, because I just couldn't. I mean, I remember once I did an implant dentistry surgery. I wasn't happy with it. And I couldn't sleep at night. I rang him next day, I said, can you come back? And I just removed the implant and reposition it, and I could sleep well. And it's been fine for the last 15 years, but I just couldn't do this. You know, someone could do this, and there's not a failed implant here that's coming out. I would say, these are the problems that I'm faced, unfortunately, sometimes when patient presents in a very complex time. So, you know, complication, this is a failure, it's not complication. Everything that can possibly have. So don't blame the implant company, don't blame, it's just blame yourself for in this particular case, or wrong planning. It's incorrect. Everything that's been has been incorrect. I mean, now these implants are actually integrated, but you could just unscrew them, just get them out. So the problem I have is that now we have a patient's damage, and we have to reconstitute the patient into, make a full denture, which you hate in the first place. And she has to wear a full denture, and she can't come in. And she's just basically, life's been put on hold, but she's a beautiful human being. So look, when I'm ready, when this is over, I'll have to come in and get it. And I'll show you the case when we finish this patient. But the problem I'm trying to make is, we're going to talk about dental implants. Risk complication, history of tooth loss, patient factors, time, age. If it's only caries, the risk is relatively low. Once you compare it on disease, it gets a bit higher. This is just odds ratio, roughly. It's not real odds ratio, just give you an idea. Once you get tooth fracture, it increases. Once you start combining, you get ninefold. You add that to the other patient factors, confounding factors, polypharmacy, etc., gets bigger. Okay, time, age, with time gets more difficult. Okay, I have a lot of patients, for instance, have all sorts of medical problems, but implants are holding very well. They're actually the only thing they can chew with because teeth are failing from root caries because they were taking the calcium channel blockers, and unfortunately, all the blood pressure tablets or other medications they're on, it creates a dry mouth. They have a motor disability, they can't clean their teeth. So a lot of these patients come in once a month and my therapist clean their teeth. That's an option that they decide to have because they can be treated and they can, a lot of them can afford their teeth cleaned. So bring it once a month. It doesn't matter as long as you can maintain good hygiene for these patients and to improve their quality of life. Well, we talked about planning for results and not for procedures. That means getting diagnosing. This is what we teach at the ICO DP education. We teach how to think, look at your cases. When you present your cases, you'll be presenting and be asking a lot of questions. I'm going to ask you to read the literature. I'm going to help you in terms of how to formulate your own way of thinking, how to think in a direction and be able to formulate your own way of treating your patients. We are trying to help you to build your, your style in terms. The take-home message is that, this is not a complication that affects the clinician's ego, By 100% fail affecting the patient's state of being, So stop and start thinking. We should. This applies to me as well, okay? No amount of empirical recipe bullshit can save the day. You just forget it, That's what I'm trying to explain is that when we look at risk assessment, okay, and you talked about selling all your patients the case, and based on the diagnosis, based on the complications of the proposed treatment that you're telling your patients, okay? And based on how will you attain your consent, a patient's ready to go to this complex treatment plan that you put forward. My question is to everyone, including myself, is that, doctor, can you deliver? So at the end of the day, you need to answer that question to you. It's a real chess game. Complex dentistry is a real chess game. Doctor, can you deliver? This is my last slide. I've given you something to think about, something to take home with you, and look after your patients. So Stan, thanks for joining us. Any comment you'd like to make?
No, thank you very much. It's just following that and treating an individual as an individual overall, not just particular sort of situations.
That's right. That's right. Alex?
Yeah. I'm just amazed. I'm just baffled with the stuff I see. I just can't believe that. I mean, the length of time what that woman's had to go through is just, I'm just baffled. And it's not the first time I've seen stuff like that.
Oh, well, you see them all the time. I mean, we know about this, but I had to bring this case up. As much as it's like something like I get told by my colleagues, Dr. Sarkis, it's really harsh. You should be, but this is reality. I'm seeing these patients all the time, Alex. I mean,
I'm almost like, what are these people thinking?
Well,
those implants were like coat hangers. You could hang them like they were coming at it from the side. They were just straight out like that. Well, what's all that about?
I'll tell you, I see
Pin the tail on the donkey.
But that's a
The
problem.
implant, wherever you feel like it, you know?
You see, the problem is that I think, when we talk about education, and it takes time to obtain knowledge, because knowledge takes time. You don't genetically inherit knowledge. If your father's a good dentist or a good doctor, doesn't matter. You don't suddenly become a good person. You need to take time to learn and read the literature, because experience is one thing, but you can have the wrong experience. You see, it's all about having the right experience. That's why I put the college together to give the students the right experience, because I can teach a monkey how to drill a bone and put implant. As far as I'm concerned, the practitioner who put those implants was no different from a monkey, because that's what monkeys would have done. Just stick them implants in. You know, so it's just so different. So how do you then tell the patient that, you know, dentistry, you know, there's a lot of good dentists out there, because they lost their whole faith in dentistry. You understand what I'm saying? It affects the whole profession. See, we don't see that. But today, you know, when someone's reading, I said, well, it's integrated. What do you mean it's integrated? I wish it didn't integrate. I wish it would come out. See, people pay a lot of money for this. They go take the superannuation money to sell a real estate or a part to pay for this. And we're dealing with the biology. We're not dealing carpentry. Okay? There's a lot of money at stake, a lot of time, effort. And if 10 years' time, people lose their implants because they've, you know, it could have been prevented. Well, of course, people are also, patients are also just as much responsible for maintaining their regular checkups, making sure that you see them. I mean, they also have a responsibility. But this particular case, there's nothing the patient could have done. Would you agree on that?
Bit too late.
That's right. Any other questions we have?
No, Dr. Sarkis, everybody is sending very beautiful thank you messages for you. Fantastic presentation.
Well, thank you very much.
Suman says, thank you, Dr. Sarkis. Amazing to see such a case from our dental colleagues. Often seen this in Bali. And few other people sending you thank you messages.
Well, thank you all.